Okay, so I will introduce myself. So I'm a cardiothoracic radiologist from Boston, Massachusetts, and I have some accumulated a sample of a few interesting cases. So I'm going to try and introduce you to those cases. We'll start with the warm-up case, and then we'll put progress to other cases. Okay. So are you ready, guys?
Ready whenever you are.
Okay. So let's start. So this is a warm-up case, and we're dealing with the patient who came in for lung cancer screening. And you see this, you have one image, and you need to find the abnormal finding and tell me what you need, what will help you decide what that lesion is and what you want to do next. So does anybody want to take this? Okay, anybody? Okay, so first of all, because we're going to deal with the heart, so you can probably see that we have a lesion in proximity of the heart. So the lesion is right here in the anterior mediastinum. So what is it in close relationship with? And what will be the differential diagnosis because of that proximity? So you probably can see that it's very close in very close relationship with the pericardium. So for that thing, so of course, a size measurement will not help you much in determining the nature of this lesion. So you have to look for something else. So for example, one of the things that will help you most, of course, if you can compare to other studies, that would be helpful. But suppose that it's been stable for like a year or two. Does it help you? Of course not. The only thing that it helps you define is that it's not an aggressive lesion. But the best thing that will help you is actually attenuation. So I'm going to give you another image, and now you can see that this lesion is probably some fluid. So basically, it is supposed to be some cystic lesion. So so if it's a cystic lesion, then it defines our differential diagnosis. And then the next thing that we can formulate, that can help us formulate the differential diagnosis is the location. So for example, if we're talking about a duplication cyst, it's probably not the typical location for that. So because duplication cyst, whether it's bronchogenic or enteric, esophageal, it should be posterior. So this location, the only thing that can be considered are either pericardium, because it's in close relationship with that, or maybe thymic cyst. Why do I not think it's thymic cyst, even though I still place it in the differential diagnosis, but I say that it's probably of lower likelihood. And the reason is that if you look carefully at the cystic lesion, you see that it bursts inside. So it's probably centered around the pericardium. And that's why probably pericardial cyst is much more likely than thymic cyst. But of course, if such a thing were to get much bigger and more ugly, we can never exclude thymic cystic neoplasm, which can invade surrounding structure. And that's why we still include it in the differential diagnosis. Any question, guys? So I think we can go to the next case. Okay. And before we go to the next case, basically, pericarditis is a benign congenital anomaly, and sometimes it can appear in adulthood as a sequel of pericarditis. It's usually asymptomatic and an incidental finding. Sometimes we can see chest pain or dyspnea, especially if it's a large lesion. And the most common location is on the right. So basically, the location we saw on this image is not that common, but it's still possible. Okay. So let's see. The next case is a patient who came for assessment of opacities and dyspnea. And you have two images, and we need to find the diagnosis, which is, of course, incidental. And we can say that the options are persistent left SVC, partial anomalous venous return, aortic dissection, or none of the above. I'm going to give you a couple minutes to understand what the option is. Okay. So, as you probably saw, I hope, especially on the axial, you can see that there are two vessels. So this is one vessel that probably gets the left brachiocephalic vein. And here we see some structures probably originating from the aortic arch. And on this side, we see some vessel that is quite large and is not supposed to be in that location. And if we look carefully on the coronal images, we can see that this structure comes from here. Now, the two options, so basically it's not aortic dissection, because we don't, if there were aortic dissection, I would have shown you some image that showed that, and we don't see it. And the only two other options are a persistent left SVC and partial anomalous pulmonary venous return. So how do we decide? So if we look at the coronal, if it were the persistent left SVC, it should have gone this way to showing either the left atrium or right atrium or some structure that drains into them. And we don't see that. Instead, we see that it turns into the lung. So the only option here that is viable is a partial anomalous pulmonary venous return. And here I'm showing you a scan, actual scan. So you see that it goes right into the lung, okay? And it goes right here. So partial anomalous pulmonary venous return is quite rare, and it usually creates a left to right shunt, because what happens is that it's actually a pulmonary vein that usually goes to the left brachiocephalic vein, and via that connection it goes back to the right atrium. So basically we have oxygenated blood going back to the right atrium instead of the left atrium. So it's a left to right shunt. Now, the biggest problem with that is that if it's a large vein draining into the left brachiocephalic vein, it can be symptomatic because it can cause volume overload on the right heart. We have a few classifications according to the site of initial drainage. And this one is usually subcardiac because it drains into a vein and not into the heart itself. Usually, it's more common when it comes from the left side rather than the right side. This is generally about this entity. Let's go to the next case. And here the patient came for coronary CTA to evaluate some history of coronary disease. I'm going to show you a video, and you need to detect actually it's only a picture. So you need to detect the silent finding. So the options are organ infarct, coronary dissection, left ventricular dissection, or left ventricular aneurysm. And you need to tell me the finding. So what do you think it is? I'm gonna give you another second. Okay, so I don't know if you noticed, but if you look carefully at the left ventricle, you will notice that it looks a little bit weird. And what do I mean by a little bit weird? So as you can see right here, you see that there is subtle hyperdensity in the left apex. You see all that hyperdensity. In some areas, it is a little bit more conspicuous, like this one and this one, but you can see it all along the left apex, stretching from almost the septum all the way to the left other chest wall, ventricular wall. And that is usually a manifestation of an infarct. So, and the right answer is an old infarct, but also a left ventricular aneurysm, and I'll explain why. So whenever you see any evidence of a possible old infarct, you really have to find out if we have an aneurysm. It can be quite difficult on a non-contrast study, but you will see that the left apex looks a little bit wider. So usually when you see a normal apex, it should be smaller, like this. And here it's not just bigger, it's rounder, and it looks like it bulges laterally and to the apex. So let me show you this photograph, this image. So you can see here very clearly that this is the left ventricle. You're not supposed to have this collection of contrast is so separate from the left ventricle. So basically, this is an aneurysm. Now the question is what you need to look for. So the options are left ventricular rupture, thrombus, coronary stenosis, or none of the above. What do you think, guys? So whenever you see an aneurysm, you need to look for a thrombus. And the reason is that, don't forget, an aneurysm in this area, this whole area, if you compare this muscle, you will see that it's much thinner compared with the normal ventricular thickness. So it means that this area is in fact, it's actually a scar. And the scar does not contract. Instead, what happened there is that it's a collection of blood settling there, and the blood there moves less well than in other locations in the heart. So every place where the blood is not moving or not moving around in a smooth way or in the normal way, it tends to produce clots. So usually, an aneurysm is a dyskinetic area of the left ventricle, usually following a prior infarct. It can be in 5% of patients with ST elevation MI, usually 5 days to 3 months after infarction. And the main complications are intramural thrombus, which can embolize, impaired cardiac output, because the functioning heart can pump blood into the left ventricular outflow tract, and the aneurysm. So basically, the stroke volume can actually decrease. And of course, that part can rupture. And I want you to look at this clip and see how it looks in real life. Give me 1 second. Sometimes it's 1 second. I'm gonna reload it. So I don't know why it's not working. Maybe there's some problem with the video. But anyway, you can see that this area is again bulging, and it looks different from the rest of the myocardium. And it looks like a sac of contrast with thin myocardium. And you have to look for a thrombus anywhere inside. But we don't see in this case. Okay. We have another case, and this time the patient is after cabbage, and we got a rollout PA study. So now, so we have this rollout study, and we need to see what you think. Do we have activization of contrast? Do we have surgical material? Do we have aortic dissection, or none of the above? I'm going to give you a few seconds to look at it. Okay, so that is for sure surgical material, and I don't know if you noticed, but it's probably those things. So you're seeing some hyperdense things, and honestly, it's so difficult to differentiate it from real contrast. And the person who read this can actually call it activation of contrast. It's a big drama because a patient after coronary bypass, why is it such a problem? Because at these locations, they sometimes connect they actually connect the bypass to the machine, so they can actually operate on the heart. So this is quite concerning. But what do we need to make sure that it's actually surgical material and not some activation? So you have the option of repeating contrast in 1 month, doing echo, doing contrast enhanced MR, and enhanced chastity, and none of the above. I'm going to give you a couple of seconds. So what you really need is an enhanced scan. So basically, you can see that the patient came back to our, so basically the patient was transferred to our institution, and the surgeon said, I don't think it's a activization, I think it's a surgical material. But again, because it's the order, you have to prove that, because you don't want to deal with a ruptured order on your conscience. So we did obtain a chastity, and you can see clearly that is, again, it's not activation, because if it were contrast, it would be washed out. Anyway, so this is definitely surgical material. And usually, these are pleasures that they put in the holes where they connect the bypass machine. So that's why it's so important if you are concerned about any aortic abnormality, especially after surgery, you have to do a pre-contrast phase, because sometimes as you can see on this image, it's impossible to see any difference between that and contrast. And only the pre-contrast phase confirmed that it's actually surgical material. Okay. The next case will be evaluation of anomaly detected on echocardiography. And here we have an option of anomalous origin of LED, persistent left asphyxia, right aortic arch, or none of the above. And let's see the scan. Let me see if I, because it does work on my computer, so I don't know what's the problem here. Yeah, on my computer it works perfect. Let me see again. Loading, and let's see if it works. It will work this way. Oh yeah, it's working that way. This way. So what is finding? Let's see if it works better now. So this is white autocache, okay? And do you see any other findings on this scan? And this time you have a few pictures. So the other findings that we can see are aortic dissection, the reticulum of Komarov, left innominate artery, none of the above, or A plus C. A few minutes. Okay. So the finding is the reticulum of Komarov. And there's also left innominate. So basically, when you think about right aortic arch, usually there can be other anomalies associated with that. So basically, right aortic arch, unlike the normal course, it courses to the right of the trachea and spinal column. It's not very common, and it's usually asymptomatic unless we have a vascular ring, especially formed by the arch and by the aberrant innominate or left subclavian coursing around the esophagus and trachea. So we have a few configurations based on the subaortic branching patterns, and that's what I mentioned. It can be either aberrant left subclavian artery, or it can be left innominate arteries, and this really is case by case. And this finding is sometimes associated with the diverticulum of Cromwell. And I have to show you this way. So you can see, when we go up, you can see that first of all, it's a right aortic arch. And then you can see that this is the diverticulum of Cromwell. I will show you. You see, this is the diverticulum of Cromwell, and you see that it is a blind-ended vessel. And then if you go further down, so we continue with the arch, and then we go back up. So we can see, so this is the left innominate, which is a mirror image of what we normally see. And then we can see that this we have a separate origin of the right subclavian and the right common quadrant. So basically, it's a mirror image of what we usually see, because usually we have right innominate, left common quadrant, and left subclavian. And here it's exactly the opposite. Okay, let's move forward. We have another case here. So this is patient came with bacteremia and sepsis, and we can see that this image. So I'm gonna go back out again so you can see the video. And the question you can answer is, first of all, which is the silent finding, and it can be either mediastinal abscess, pneumonia, infective endocarditis, periaortitis, or none of the above. So I'm gonna go back out. Now you can see the video. What do you think? Can I show you again? Periotitis, because first of all, you can see that the patient has a graft here. So whenever you see a graft and you see a patient that has a bacteremia, the first thing you think is a graft associated infection. And you can see that surrounding this order, there's all this soft tissue thickening. This is not normal. This is not normal. It is infection until proven otherwise. So it's very serious finding, and it's probably infectious otitis. And it's an emergent case. So basically, the patient needs blood cultures and his broad spectrum antibiotics, and then it's a big problem because whenever we have infectious otitis, big trouble, very big trouble. Okay. And the next case came for evaluation of coronary disease, and you need to tell me what the silent finding is. And I'm showing you two pictures, and the options are left ventricular aneurysm, left ventricular thrombus, dissection of LED, none of the above, or A plus B. I'm gonna give you a few minutes. Okay. So the correct answer is aneurysm plus thrombus. So again, just as I showed you before, you can see that there's pulling of contrast into an expanded portion of the ventricle. And contrary to what you see in the other ventricle, which has normal walls, we can see that the myocardium here is very thick, very thin. And then we see contrast here. And if we go further down, we can see that the aneurysm progresses. And we see that there's hyperdense material which had to be thrombus. This thrombus, you can see that it's not organized. So it means it's not adherent to the actual ventricular wall, which means it can embolize and do brain infarct, and it can do splenic infarct and kidney and anywhere. So this is very dangerous. Okay. And see if I can show you the movie here. So basically, it's a picture. You can see that this is the thrombus. So this is the aneurysm itself in the left ventricle, and this is the thrombus. Okay. The next patient came from pre-surgical evaluation, and we need to find what finding the surgeon wants to operate on. We have complete LED occlusion, RCA dissection, anomalous LED, mitral valve prolapse, or none of the above. Okay, I'm showing you again. So the salient finding is mitral valve prolapse, and I'm going to show you again on the video. So first of all, if you look carefully, you will see that the left atrium is quite distended. And as much as you probably, sorry, give me 1 second. We look at the mitral valve in a second. I'm gonna speed it up a little. Like it's hyper-expanded, it's precisionist, and it bulges all the way into the left atrium. So that is classic mitral valve prolapse. And so basically it's bowing of the mitral leaflet, and it has to be 2 millimeters beyond the annular plane into the left atrium. is a common cause of mitral regurgitation, especially if we're talking about non-ischemic causes, and usually we diagnose it with a echocardiography and not on the CT, but here it was a very nice finding. Now we have another case, which is for which we need to decide if it's a acute dissection, coronary fistula, right ventricular pseudoaneurysm, coronary dissection, pulmonary embolism, or none of the above. I'm gonna show you the video. Sorry. Okay, I show you again. Okay. So the correct answer is right ventricular pseudoaneurysm. Okay, so I'm gonna show you exactly. Give me 1 second. There's a picture, I think. So as you can see on this image, you see that there is a hypodense finding adherent to or in the location of the pericardium. So if I show you again on the video, let me show you. So if you go further down a little by little, you can see that this thing gets a little bit smaller. And then you see that it continues right into the right ventricle. So that is some kind of an aneurysm or pseudoaneurysm that happened because of the surgery. It's a complication. And initially, we didn't know if it were related to the coronary vessel right here. But again, if you look carefully on the image I show you subsequently, you can see that there's a clear fat plane separation between this finding and the coronary vessel. So it's not related to the vessel. And as I showed you on the video, you see that there is a continuation between that finding and the right ventricle. And that means this is probably a right ventricular pseudoaneurysm as a complication of the surgery. The next case, we need to decide if it's a primary cardiac tumor, pericardial sarcoma, pericardial metastasis, or pericardial hematoma. I'm going to show you the video. Let's say it again, but this time only from the middle to speed it up. Okay, so I think it's a pericardial hematoma. And now you need to answer me what scan you would need for better assessment. So if you remember, this is a contrast study. So basically the best thing that you need is actually an unenhanced phase. So remember, whenever you have a question of bleeding, hematoma, anything that is related to the surgery, you need a pre-contrast study. So basically, all those hyperdensities are actually not activation of contrast, they are calcification. And what happened to that hematoma, it probably happened during the surgery. And instead of completely regressing, it stayed that way and it organized as part of the pericardium. And as anything that stays for a prolonged amount of time, it tends to calcify. So that's why it's probably pericardial hematoma. So, give me 1 second. So we have a lot of causes for pericardial hematoma. It can be iatrogenic after a surgery, especially coronary bypass. It can be because of trauma, complication of other heart conditions, including ischemia, or because of inflammation. And the main complication is the tamponade, but sometimes it just does not regress. It just gets organized into the wall of into the pericardium, and it calcifies. Okay. We have one last case, and the last case we need to decide if it's aneurysm of the aorta, aneurysm of the RCA, anomalous RCA from pulmonary artery, or none of the above. I'll show you again. So the correct answer is anomalous RCA from the pulmonary artery. And as you can see, I'm going to show you again the way it looks like. So this is the pulmonary artery. And you can see that if I progress a little bit, you can see that this vessel comes from the RCA. And you can see that it's this one right here. So it comes from the main pulmonary artery, and it courses in this. It takes the same course as the regular RCA, but it's just the origin that is abnormal. And let's see what we know about the anomalous coronary artery from the main pulmonary artery. So usually it's a very rare phenomenon, and we can think why, because it causes ischemia. And because of ischemia, usually the babies that are born with that either die in utero or they die very early in the course of their lives because of heart insufficiency. And the result, and the reason that they die from that is because it causes coronary stress syndrome. And why? Because what happens is that right after birth, if you remember from physiology, the pulmonary circulation drops significantly in pressure, whereas the systemic pressure goes sharply up. And that way, the blood will usually flow to an area that has a lower pressure, which is usually the pulmonary circulation. So basically, it will steal blood from the coronary distribution. And that's why it's very uncommon. This is potentially deadly, and even more so if we have the left coronary system originally from the main pulmonary artery. So this usually mandates surgical. Any questions, guys?